Welcome to Heart Blocks. In our previous section, we focused on arrhythmias that arose out of the AV junction, either SVT or actual junctional rhythms. In this section, we'll talk about what happens when that portion of the heart isn't functioning properly at all in terms of actually shutting off or delaying. Quick reminder, AV junction is the AV node and the bundle of His as a group. The sinus node, those rhythms I'm actually going to reserve for the advanced arrhythmia group, and that'll be part of that lecture when that comes around. But without delay, let's dive right in. AV blocks, atrioventricular blocks. For those who prefer to visualize the anatomy, here's a picture that I borrowed just to kind of give you an idea of what we talk about. That the AV node is not the AV junction, it's a group of items. So we'll say this, that the AV junction is actually the AV node and the bundle of His. And this, I like this one because it really helps you visualize. And just to make note that, to give you an idea, right through about here, this is the atria, and this is the ventricles. That AV junction has a foot in each door, essentially, but is also the gatekeeper and the only way through, naturally, that you can connect the atria to the ventricles. And it's where the bundle of His splits into two parts with the right and left bundle branch. That's when it no longer becomes the junction, and it winds up being the bundle branches instead. So things that are important concepts to keep in mind here is that delays can happen along any part of the AV junction. It can be just this part of the AV node maybe is broken. It could be all of the AV node, or instead of the AV node, perhaps it's the bundle of His that winds up, dying out or quitting for some reason, and then you're not able to get a full signal through. And that's the hallmark of these AV blocks, is that something somewhere as part of this AV junction is damaged or busted and is causing delays or complete blockages of the electrical impulses trying to get through. If you want to hear the official phrasing for it, it is the atrioventricular block is defined as a delay or interruption in the transmission of an impulse from the atria to the ventricles due to an anatomic or functional impairment in the conduction system. A little boring, but that's the truest way to say what's going on. Now we'll go forward and take a look at what those actually encompass. This list is combined. It includes both the basic arrhythmia and the advanced arrhythmia group. So we'll start first with the basic arrhythmia list of what all's in here. AV blocks include first degree block, which you've got here, and that essentially, quite simply, is when is defined or found by having a PRI that is greater than 0.20. All of a sudden, now you know why we've been measuring it this whole time. That's finally going to start paying off. So, 0.20 seconds without any interruptions. Every P has a QRS, essentially. Now, in second degree block, and this is kind of how we abbreviate those: first degree AVB, second degree AVB. Second degree is divided up into two types, the Mobitz type and the Winky-Bach type. Now I'm going to go back a slide real quick and if you notice, you've got Winky Bach written here at the top and Mobitz off to the side. Just has to do with the gentleman who did a lot of the figuring out. Don't focus on that. Modern terminology simply notes both of them as being Mobitz, but divide them up as being type 1 and type 2. And that's what I want you to focus on, is type 1, type 2. The overall defining characteristic of second degree AV block is intermittent conduction. An intermittent conduction of the atria to the ventricles. And so what that means is you're going to have more P's than QRS's. Whereas with the first degree block, you're going to have 1 P per QRS. And the simplest way I like to help people remember these is for Winky Bach, or for type 1, Winky Bach's a fun word, and it's usually the first thing you remember. And so type 1 is Winky Bach. And it has a fun little phrase, which is going, gone. And what that means is that the PRI increases with each successive beat until there's a dropped beat. And I'll walk through this stuff in more detail. I'm just giving you the high view right now. As for second degree, type 2, what makes this one unique is that the PRI is constant. And that really is the only difference between type 1 and type 2. Type 2, the PRI is always the same. Type 1, the PRI increases, it gets longer. Finally, third degree block. In a couple different ways people say this. They can either say third degree AVB or call it complete heart block. Both are acceptable. What happens in this situation is that there is no conduction. Essentially, anything happening in the atria is completely blocked from making its way into the ventricles. And so none of the P's, you may have P waves, but they're not doing anything. They have no value because they're not communicating with the rest of the heart. And that pretty much wraps up what we're going to talk about with basic arrhythmia. The rest of this will be in the advanced arrhythmia section. Mechanism of first degree heart block, also known as first degree AVB. The idea is that there is a delayed conduction, and only delayed, through the AV node or AV junction from the atrium to the ventricle. So the idea is that you have 1 P for every QRS, but that delay creates a PRI greater than 0.20. This may be, if it's not the number one thing that we see most common looking at strips, it's got to be the number 2. First degree heart blocks are actually very, very common, and they're really easy to spot because it's a simple matter of measurement. The QRS will be perfectly normal. It should conduct without any difficulties whatsoever. You just have a longer PRI. The rules are really simple. In fact, I've already gone over them in the previous slide, first degree heart block. The rate is entirely dependent on the underlying rhythm. You can be bradycardic or tachycardic. Both are completely possible. The regularity, it just depends on the underlying rhythm. If the patient's throwing PACs or something else like that, that's an ectopic beat. It's separate from what we're talking about here. When you see your P waves, they should be upright and uniform. Each P wave will be followed by a QRS, that kind of stuff. The big one is this, that PRI is greater than 0.20, and it's constant and the same every single time. It doesn't get longer or shorter or anything. It's whatever you measure it at, it will be the same every time. And then your QRS is perfectly normal. This is a sinus rhythm. with first degree AVB. The biggest thing I want you to take out from this slide is just how big that PRI is here. You've seen a couple of them already, so you should be able to at least recognize that that's a lot longer than it should be. But we have one P wave for every QRS. The P waves look normal. It's just a longer PRI. That's what makes first degree block first degree block. Why is it important? Why do we pay attention to the AVB? Well, we go to all this work measuring, so you might as well take credit for the work you did, right? That's one part, but that's not the reason. Why we pay attention to this is it's not normal. You aren't born with it. That's not how your heart is supposed to function, so therefore we should make note that it exists. The reasons or the times that it really matters is that if it's a new onset, or if that number's getting worse, if it starts out as being, just a little bit over, maybe like a 0.24, and then later on in the shift or a day or two later, it winds up being 0.38, that's a massive change. It's gotten a lot longer. That's a sign that things are getting worse. Most folks really have this and there's not much treatment to do. They're asymptomatic. We just, hey, that's you plus first degree block. But we keep an eye on it all the same. Now, aging, it is part of the aging process. Your heart doesn't get healthier as you get older. It can only wear down. Ischemia is a good one. Vagal tone, if someone does vagal stimulation, it can make that worse. Medications that affect the AV node can be part of that, or the AV junction. And then if you got a stretched out heart, or if you've just had heart surgery, those are different things that can cause this to flare up. Overall, first degree block is only serious if it's new or is getting worse. I've alluded to it already, but I wanted to give you guys a visualization of what I'm talking about when I say blocked P waves or dropped QRSs. Now this is something that occurs in your second degree blocks and your third degree blocks. And that's the idea. And of course, this little text box here explains it a little bit, but if you look here, you've got a normal PQRS. That's just the way it's supposed to look. But then you see all of a sudden you have a P wave and then you're missing your QRS right here. And that's what we're talking about, is that this P wave was blocked from conducting, and so you wind up dropping a QRS. And so that's just the overall concept. And so you can see in this one you actually have 3 blocked P waves in a row, which causes 3 QRSs to be dropped. And we kind of use that language interchangeably when we're talking about these things. And for those who are curious, this one here is a second degree AVB Type II. And the reason this one is a Type II is because the PRI is the same every single time. You just have a series of beats that fell through. Mechanism, second degree heart block type 1, also known as second degree AVB type 1. This one, what makes it unique is the fact that it is intermittent atrial conduction to the ventricle. With a first degree block, the P wave will always create a QRS. With second degrees, some of those P waves just don't get conducted through. Now, with type 1, you usually actually see a pretty regular pattern that winds up occurring, something that's pretty predictable. Not always, but oftentimes. What you're looking for in this pattern, or the specific thing you're trying to find, is that your PRI will increase with each successive heartbeat until one P wave is not conducted. When that happens, the pattern resets itself and then repeats it over again. So maybe it's every 4th beat that doesn't go through, or maybe every 6th. It could always be variable, but that's what you're looking at. You're looking at the PRI, measuring it with each one of those beats to see if it gets longer and longer until it drops. And that's where I get that phrase I'd mentioned before, which is going, going, gone. block is, of course, right here, and it is intermittent, or intermittent. And so that, yeah, you should have your normal sinus beats, just occasionally some don't go through. Your QRS should be perfectly normal, though. There shouldn't be any problems there. The rules for second degree AVB Type I, your atrial rate should be pretty well normal. It can be from 60 to 100. It may be slower, it may be faster, but most of the times it's right in that normal range. What is important, though, that with a real good second degree Type I, most times your ventricle rate's going to be slow. So these tend to be bradycardic, and that's going to be one of your hints as to what's going on. Not only the dropped beats, but the fact that it's also a slower heart rate. This is definitely going to be irregular for sure. I didn't touch on it with the previous slide, but I'll mention it here. The R to R interval does get shorter as the PRI gets longer. And there's a pattern to that comes out of it, which is where I get the grouped beating mentioned there. But the idea is that the PRI gets longer, so the P wave is closer to the R wave. And that winds up kind of tripping things up a little bit. We'll look at some examples, and hopefully it'll make more sense when you actually see it in action. Your P waves should be perfectly normal, except some of them are not followed, so you're going to have more P waves than QRSs. The PRI should always be greater than 0.12, but I don't really have a top end for that. It just progressively gets longer until one's not conducted. So it's very, very likely that you'll have one of these that's maybe even greater than 0.20, and that's perfectly acceptable. Your QRS, though, should look just normal. There shouldn't be anything crazy going on there. Here we have second degree AV block type 1. And so we're going to talk about the two different things. What makes this second degree? Well, it's going to be dropping of the QRS. So if we look, we can see that we've got P wave here, here, P wave, P wave, P wave, but we're missing our QRS. And in fact, if we look back, we'll see we have a P wave missing a QRS. So that dropped QRS is what makes it a second degree block. What makes it type 1? Well, if you look at each of these P waves, you'll notice that the PRI gets longer with each beat down the line until you drop. And if you look back, you'll see that we dropped a beat here, but then the next one had a short PRI. And in fact, if I compare this PRI here to this one down here, we'll actually find that they match. And that repeating pattern of going, going, gone is what makes this second degree type 1. So why is the second degree AV block type 1 so important to know and understand? Well, it's never normal. You're not supposed to be in that rhythm, so it only occurs in situations where there's something wrong or something's changed about your heart. A heart attack, specifically inferior MI, and that's going to be your right coronary artery is the one that we're looking at there. It's highly likely, especially if this is new onset, that it's due to something like that. That being said, the cause isn't the only thing that we need to look at here. Significance, importance. It could be due to a heart attack. Ultimately, these are unstable by nature, especially for as slow as a heart rate can get, because then with a low heart rate, you wind up, the bradycardia over here, you can wind up with a low cardiac output, and those are things like syncope, they've passed out, maybe have low blood pressure, hypotension, or even just could be dizzy. things like that. Like, it can go anywhere along that spectrum depending on how bad and for how long this has been occurring. The real danger, especially if it's a new onset, is that it can progress into third degree heart block, which is much worse by far. So we need to be really aware that that's something that can occur. Ultimately, triggers, just to talk about triggers real quick. Ischemia, we talked about that with the MI. Cardiomyopathy, which is a enlarged heart. High potassium, hyperkalemia. So that's why we check those labs and we correct those when we can, or when it needs to be done. Medications, those are always a bit of something that could do it. We're looking at stuff like beta blockers, or cardizem's a good one, amiodarone. Medications we give quite frequently to a lot of our patients. That's why medication management is so important to prevent things like this from happening or getting worse. A high vagal tone, just if your vagus nerve's overstimulated, and hyper and hypothyroid can also be triggers for this type of thing to occur. So treatment. Let's talk about what you can do to help these folks if they do come across. You just follow your ACLS. And so you're actually going to start out with atropine. If that winds up helping, awesome. Dopamine, dobutamine is probably your next best bet to help maintain things. If that's not effective or not effective enough, that patient may need temporary pacing, either through the pads, so the ones that are on their chest, or they may have to get a special procedure done where they can get the temporary pacemaking wire placed. And temp pacer wire. So those are the couple of different things that can go on in those scenarios. And that's why it's important, and that's why we focus and hone in on the fact that when this occurs, what are we doing to help guide treatment and help make sure the patient improves. Second degree AVB Type II. What makes this unique and important? Well, at its core, what it is an intermittent atrial conduction to the ventricle. And so that's why we have this marked here as blocked. But I again want to point out that it's intermittent. And that's because in this scenario, what occurs is you often have a regular pattern or frequency. But with that, by the way, that's not always. But that pattern and all of that kind of stuff, what it really boils down to is that your PRI remains unchanged. And that's the most important part on there, that each PRI is the same, until suddenly a P wave is not conducted, and that goes right back to being exactly the same PRI it was beforehand. And that's what separates this from second degree Type I, where in Type I you get that PRI that gets longer and longer till it drops. This one remains consistent all throughout. And also, you should have a normal QRS conduction. Another way to look at it is that the AV node or AV junction will selectively conduct beats. Once it's in the ventricles, though, things are just dandy. As for the rules for second degree Type II, you're going to be looking at your atrial versus your ventricular rate. The atrial rate should be pretty well normal and not too much going on there. Your ventricular rate will very nearly always be bradycardic. That's kind of the big focus there. As for your regularity, it really just depends on the conduction that's occurring. Sometimes it is perfectly regular, other times it is quite irregular. It just depends on the person or the strip that you're looking at, because people can change throughout a shift. I've definitely seen that more than once in my time. As for your P waves, they're just fine. They're upright, they're uniform, but you will have more P's than QRS's. And if you have a regular pattern, it's really beneficial if you can figure out what your ratios are. It's like, is there 4 P waves for every QRS? Or is it, 3 P waves for every QRS? And that's what we're talking about, is P to QRS ratios. Your PRI, it's going to be greater than 0.10. It's common to see that it's prolonged, greater than 0.20. And that makes sense, right? If first degree block happens because the AV node is not functioning properly, and then second degree block happens because that same AV node, AV junction is functioning even worse, you can kind of stack those two on top of each other and wind up with someone who has a long PRI and is also dropping beats. And we'll talk about the name for that in a little while. And of course your QRS should be just fine. Second degree AV block type 2. So what makes this a second degree block? Well, you've got your P waves, but then you've got your dropped QRS's there. So that's the first part of it that makes it a second degree block. The second part is that your PRI is consistent every single time. Now this one, granted, is dropping every other beat, but if you'll notice, every single time we have a PRI, they are the same. So by definition, this is a second degree type 2. And they're also more worrisome. I mean, this patient only has 3 heartbeats in this 6 seconds, so 3 times 10 gives us a heart rate of 30. So these patients are usually in a lot worse shape than when they're in a second degree type 1. So we'll talk more in the next slide about what to do about that. Why is second degree AVB type 2 important? Well, similarly to type 1, it doesn't happen normally. It's because something is wrong with the heart. Most oftentimes it's due to ischemia. And so what we're looking at is possibly a heart attack is the first thing we assume, especially if this is new onset. Yeah, because anytime it's new, it means something changed. So we always think about a heart attack. If it's a heart attack, it is likely the right coronary artery that's responsible. Regardless of that part, if this second degree block occurs and then begins to worsen, that progression into third degree block is what we're really concerned about. We definitely don't want that to happen. We want to intervene before that occurs. Triggers, like we said just a minute ago, ischemia, so heart attack. Cardiomyopathy, you've got a stretched out heart. Hyperkalemia, you've got high potassium. Medications, you've got your beta blockers. Cardizem can do it. Amiodarone. High vagal tone, so you do the vagus, you have a patient vagal down a little too much, and your thyroid, either up or down, could be a cause. All that being said, what's the clinical picture? What are we looking for? Well, they're going to have an irregular pulse, right? Because there's going to be that odd pattern to things. They may feel palpitations. What we're particularly concerned about is when that heart rate gets low, like much lower than the patient would normally have, you start seeing those symptoms of low cardiac output like syncope, low blood pressure, and I abbreviate as HOTN, dizzy, short of breath, any of those types of things that you would normally expect with low cardiac output due to a drop in the heart rate. What do we treat with? Well, we treat with ACLS is the big one, the bradycardia pathway, to where you're actually going to treat with atropine if you can get it in quickly enough. If you can't, there's always temporary pacing, either with pads, or if you're at the hospital and can manage to, you can put in temp pacer and actually thread one in with the patient. And we'll actually talk about that a little bit in the pacemaking section. But those are your treatments. Again, look at the patient, treat the patient, go off of their symptomatics. If drugs work, dopamine or dobutamine are usually good choices to help get that heart rate back up and the blood pressure. Complete AV block, complete heart block, also known as third degree AVB. What's going on? What's the idea? Well, as each of these heart blocks has progressed, they've gotten worse. In first degree, they all made it through. In second degree, some didn't. And when I say get through, atrial impulses. In third degree, none of the impulses make it through. And that's what makes this a complete heart block. Actually change colors here. Totally blocked. Nothing that happens in the atria communicates with the ventricles, and vice versa. Anything in the ventricles won't be conducted backwards either. It's a total, they've been completely severed. And the different ways we explain this or express this is that the atria are electrically independent. They've been cut off. The P waves will actually look pretty awesome. They should be occurring nice and regularly without anything special going on. The ventricles, those are now isolated. So if anything happens below those, below the AV junction or below the AV node, it's entirely on them and it's independent of what's coming out with the with the P waves. So if you wind up having QRSs, they have nothing to do with the P waves that may be around them. And I'll show that to you as we go on. In terms of these patients being alive, the only, truly, when a patient's in third degree block, it is an escape rhythm that keeps them alive. That's not the focus of basic arrhythmia. That will be the focus in advanced arrhythmia, how to identify which type they are. For today, just realize that, there is an escape rhythm present, and that's what's keeping them going. What are the rules for third degree AV block or complete heart block? Or there's a couple different things that we wind up calling it. I'll usually call it third degree most of the time, because there's about only one thing that we really talk about, at least without being in a burn unit. It's about the only time we talk about third degrees. Anyhow, what you're going to see is this. The atria are going to be clipping along at a nice normal rate. There really shouldn't be anything too exciting going on in terms of the number of P waves and the rate that they're moving. But what you will see is this. The ventricular rate, the QRSs that you can identify and count, that's definitely going to be bradycardic. On rare occasions, it might actually be a normal rate, but that doesn't happen all that often, at least in my experience. What you're really looking for is this, that you have very regular rhythm, very, very regular. It's going to look uncanny, actually. But the P waves and QRSs are going to be separate from one another. And here's what I mean by that. It's that you're going to have more P waves than QRS, right? more P waves and QRSs. They're going to be upright and uniform, and that's cool. The PRI is what's really going to clue you in as to what's going on. When we talked about first degree block, the PRI was longer. When we talked about second degree blocks, the PRI either changed or was really consistent, right? There was a pattern to it, or it's stayed the same. In a third degree block, it is just, it's nuts. You can have one that's only 4 small boxes, and then 12 small boxes, and then 6 small boxes. Like, it's just up, down, left and right. It's never the same thing twice in a row. And that's one of those clues that you have. The other clue is that the P waves can be hidden in the QRS and T waves. And that's another thing that makes these very challenging to identify, because if you're not able to find all your P waves, you'll never be able to either properly measure the PRI or realize that you're in a third degree block. And so we'll take some time to focus on that part as well. Ultimately, the QRS can be normal or it can be wide, just depends on the scenario. Don't let that throw you off today. Third degree heart blocks are some of the most challenging ones to interpret. So looking at this, I would never expect you to just look at this and go, oh yeah, that's totally a third degree. But what I do want to point out is a couple very important things. One, I'm going to make hash marks above. These are the P waves here and here that you can see. And you'll notice you've got a lot more P waves than you do QRSs, right? So that tells us we're in a block. But what's more important is there's actually hidden P waves here and here that you may not have noticed. So we actually have those as well. If you did all the measurements, you'd see that these P waves happen at exactly the same distance from each other throughout. But then you've got these QRSs that the distance between each one of them would be consistent over and over again. And that's what makes third degree so dangerous, is that you just have such a low heart rate that that's where your real danger is at. But this is what third degree heart block looks like, or at least one example. Why is third degree heart block important? Why third degree AVB? Well, honestly, because it's one of the deadly rhythms, one of the deadly arrhythmias. If you really think about it, this patient's heart, the top and the bottom half, are completely separated from one another, dissociated. They're not communicating electrically. That means that this patient is in for a rough time, unless they're very, very lucky. The things that come out of this are, why is it important? Well, acute heart attack, acute myocardial infarction, acute coronary syndrome, whichever one of these you want to go with, that's an upset heart, especially if it's new onset. Usually they're going to present with syncope because all of a sudden they go from a heart rate of 60 to 80 down to a heart rate of 40 to 20. It's so fast and drops so precipitously that it's a pass out that winds up bringing them in. If they're lucky, they wind up with a heart rate. Sometimes it just might be that, that fun statistic where a large majority of people pass away with their very first heart attack. Things like this are the reason why. If they are fortunate enough to have a good escape rhythm to keep them going, you still have the risk of exacerbating an underlying problem. Because let's be honest, if you're to the point where you have this type of heart issue, you probably have multiple comorbidities. So it can take a bad situation and make it worse. So what does it present like? What does it look like? Well, they're going to have that irregular, well, it actually shouldn't be an irregular pulse. It should be perfectly regular if they have an escape rhythm. Ultimately, it's the bradycardia that we care about because of that low cardiac output. The syncope, like I mentioned, the low blood pressure, the shortness of breath that can come with it, this low BP is the one that we're really worried about. We can have change in level of consciousness. Treatments, well, depends on if they're truly unstable, which they will likely be. You're going to follow ACLS. You're going to give them atropine. Atropine will probably not work at all, so be ready, because temp pacing with pads is going to be your first go-to to help keep them alive, and then probably transition into either a temp pacing wire or a permanent pacemaker, depending on their problem. We can definitely try medications in the meantime to help bridge the gap. That's perfectly appropriate. We just have to see what winds up working out in their favor. Ultimately, what's going to cause this? Well, ischemia, we talked about that, cardiomyopathy, enlarged heart, hyperkalemia, elevated K+. Meds, same as before, anything that would cause a severe bradycardia. So that can be your beta blockers, cardizem, and you think about it, those are the meds we give for AFib patients that are running too fast, because it helps slow down that AV node and the conduction through them. Well, now what happens when those drugs work too good? Now, none of the conduction could go through, or a very, very small amount. Your high vagal tone is one, and then inflammation of the heart can do it too. Either way, it's that ACLS approach to things that always take third degree serious. That's why we make a big deal about catching it every time. The AV junction is comprised of the following anatomical parts. I've gone over this a couple different times, so there's a few different locations you can look, but your choices are the left anterior fascicle, which is part of the left bundle branch. You have the right bundle branch. Of course, there's the AV node itself, there's the bundle of His, and then there's the Mobitz portion. And hopefully that one threw you off completely and you just tossed it out altogether. But we're really looking at, the AV node and the bundle of His make up the AV junction. Which of the following statements about AV blocks are correct? We'll just go through these one by one. First degree AV block will occasionally drop a QRS. Nope, we know that's incorrect right away, because first degrees never drop a beat. Second degree AVB Type I has a consistently wide PRI with no dropped beats. That's wrong, because we know all second degree blocks drop QRSs. That's one of the hallmarks of that. Second degree Type II has a consistent PRI, which is correct, no matter what pattern of dropped beats. So that one is actually correct, because second degree Type II has dropped beats with a consistent PRI. Last but not least, third degree AVB has total AV dissociation. That's accurate. Atria and ventricles do not conduct impulses across the AV junction. So on this one, I would say that your third and fourth options, those two are accurate statements. Common presenting heart rates of second degree and third degree heart blocks are bradycardic. What symptoms may be associated with these new onset low heart rates? And so this is a question about symptomatic bradycardia, particularly in second and third degree. And so think about it. Low heart rate is usually a drop in cardiac output. So which of these are symptoms of low cardiac output? Chest pain is absolutely one. Hypotension is almost always one. Decreased level of consciousness, definitely. Shortness of breath can absolutely happen. And anxiety, because they just don't feel good because their heart rate's so low. So on this question, it's actually every single one of these answers is correct. When providing care to patients with third degree AVB, also known as complete heart block, which of the following are priorities? So this is a question of, you have a bradycardic patient, and this is one of those potentially lethal arrhythmias. What are you going to do when you care for this patient? You're going to visualize them, absolutely. Go lay eyes on them. You're going to check for a pulse. You're going to collect vital signs, because that's just what you do when you're checking on a patient, right? If their heart rate is so low or they don't have a pulse, you may have to initiate CPR. You also need to confirm whether their DNR, DNI status. That may absolutely change the way we react to that situation. Ambulate to the restroom? Absolutely not. Why would you walk your patient when they're in this bradycardic rhythm with probably low cardiac output? Definitely don't ambulate. Checking level of consciousness? Absolutely, because that's part of visualizing the patient, right? You talk to them. And then move the patient from the floor to the bed immediately. If they happen to have had a syncopal event because of this and passed out, leave them on the floor, keep the scene safe, work on them there. When there's enough help, then you can move them to the bed, but don't make that your first priority. So yeah, ambulation and moving the patient doesn't need to be done right away. The telemetry tech notifies you your patient has been in sinus rhythm, but is now in second degree AVB Type II with rates of 50 to 60s. So we're bradycardic. What first action would be most appropriate? And so this is a question of your patient has a new rhythm, a slower rhythm. How do you address that? Well, it's not something you're going to delegate to a CNA, so that one's out. Would you call the attending first and have them be the one who looks at the patient? Would you call an RRT? So we have the attending question, or do you call an RRT and have them look first? The answer is essentially no for all of those. You, the primary nurse, needs to be the one who evaluates that patient, then notify the attending. Depending on what you see may determine whether you call an RRT as your second action, that's appropriate, or emergently notifying the attending, that may be your second action. But the first thing you need to do is be that primary nurse who's evaluating the patient, then calling to let them know what's going on.